Welcome, everyone. A warm welcome on behalf of the British Computing Society Primary Healthcare Specialists Group. Thanks for all your time and interest. If you've got a chat button, please let us know what you do currently and where you're from. It's incredibly helpful for us to get an idea of our audience and our reach for the event as well. Whilst we're doing that, I think we can do some introductions as well. So hi, I'm Jung. I'm a GP academic from Manchester. Currently split my time between doing GP and research. Currently doing a project on finding an improved measure of polypharmacy using machine learning techniques. And yeah, we've got a great committee that have put this together for us. Yeah, some introductions maybe from Ian first.
Hi, so I'm Ian Thompson. I'm a GP in the East Lothian part of Scotland. And I also work for the Digital Health and Care Directorate, part of Population Health in Scottish Government. And as of November 2 years ago, I was persuaded to help chair the Primary Healthcare Specialist Group. So I'm really pleased that Young and others have agreed to help us as a group present this webinar, which I hope you will find very interesting. Thank you.
Thanks. Bex?
Sorry about that. Hi, I'm Bex. I am one of the committee members here based in Oxford. I also do other work in terms of being a Royal College of GPs, National Clinical Advisor and the National Dermatology Representative. So just happy to be here to help out today.
Yes. Yumisi?
Hi, I'm Yemisi. I'm a GP trainee. I'm in my final year. I've been opportune to join this lovely team to plan the webinar. I'm currently at Dean Cross Surgery in Plymouth, and I'm still in the very early part of my digital health career. I'm currently one of the Fed IP members of cohort 3, and I hope other GP trainees will make use of this opportunity today. Thank you.
Yumisi. And John?
Yeah, hi, I'm John Robinson. Completely the other end of my career, having been retired from practice for 9 years now. I worked for NHS England for some years. I still work with Primus at the University of Nottingham and here to support the group.
Thanks, John. And we have some others, such as James Roberts and Zara Gandon, that have helpfully put this together as well. So we've really set up this webinar because we believe there's a wide interest in people wanting to embark and get more involved in digital health careers. And hopefully we can give you some tools to do this. And there's so much momentum in tech and AI, and it's going to really have a massive impact on healthcare and the way that health professionals work. And I think we have a real responsibility to do this well, to implement systems and AI well, so that we can optimize the impact for our patients and also safeguard them as well. So in order to achieve this, we need more people like yourselves with multiple skill sets that are hungry and eager to get into tech so that we can make a proper impact together. So to this end, please do contact us if you wanted any further support or details, and we'll try our best to help beyond this event as well. So we've got an exciting lineup of inspiring speakers for you today who have really carved out very different career pathways on their digital health journey, and just to give you a flavour of what is possible and hopefully some fruit of thought on your own journeys as well. And as I'm sure some of the talks will come on to, there's no single way to do this. And in fact, it's probably the opposite. Informatics careers are much more individualistic and diverse, requiring you to actively walk through some open doors or go looking for them at times. So you saw the schedule before. We'll have 3 presentations with a few Q&A after each presentation, and then a global Q&A at the end. So please feel free to use the Q&A box as well for questions to upvote and downvote Thanks for those who submitted questions beforehand on Eventbrite. I'll post some of the more popular ones into the Q&A box once we get onto the global Q&A at the end. Right, so without further ado, our first speaker is Abdullah. He's co-founder and CEO of Medical Chain and My Clinic, initially training as an ENT surgical trainee. He then moved on to general practice and has continued his passion for innovation and in developing solutions to combat inefficiencies in the NHS. He describes himself as being a troublemaker, but his determination to challenge the status quo has led to some of his biggest achievements so far. You have the floor, Abdullah.
Hi, good afternoon, everybody. Thank you, Jung, for inviting me, and Bex for putting me forward for this talk. So essentially, I've been asked to really condense my life experiences from 2017 to date. And I'll try my best to do that in the next, say, 12 minutes or so, and I'll leave about 3 minutes for Q&A. Unfortunately, as you can see, I'm in a clinical setting right now. I'm doing my ENT clinic as it is, so I won't be able to stay for the global questions at the end. So I wear many hats. So one of them is I am a GP. I CCT'd in 2019, and I continued to practice ENT as a GP with a specialist interest in ENT. I happen to be the provost of the Royal College of General Practitioners in the Yorkshire faculty. So I used to be the chair, and I moved on to becoming the provost there. I sit as one of the members of the local medical committee in Leeds as well, which is the union of GPs in Leeds, to try to iron out problems we may have as primary practitioners, be that with our secondary care colleagues or issues wider afield. But I suppose the reason I've been asked to speak today is not because of those things, it's because of my experience in terms of health tech. So in 2017, I founded a company called Medical Chain with my brother-in-law called Mohammed Tayyab. The reason we funded this and founded this company, I should say, is because of my experience as a clinician of struggling to have access to patients' records. So if you know, as a trainee, you may be in an A&E setting, and I used to be an A&E registrar as well before I finished GP training. I wouldn't have access to patients' records. So the patient could tell me they were allergic to something, but they wouldn't recall what the exact name is. They would tell me that they had a scan in another hospital just last week whilst they were in holiday, for example, in Scotland, and I wouldn't have access to that scan, but that'd be quite critical to our decision-making or the need to rescan them and maybe unnecessarily expose them to radiation again, such as a CT head, whereas we only just did that scan a week ago in the NHS system itself. So I embarked on this journey of trying to create a platform of empowering patients to have access to their medical records so that they, what we coined as the health passport before it became a popular term during COVID, in 2017, 2018, we called it the health passport. And the idea is that the patient would have access to their primary care records, secondary care records, private health records, as well as health tourism. And they could take this with them to any clinic, show their QR code on their mobile phone, for example. The doctor or nurse would be able to scan the code, and then on a web-based interface, so on Google Chrome, for example, or Safari or Firefox, be able to open the page up and go through all the patient's records and add to it. Now, the unique thing about our system is that we were trying to build this on a technology or on a security level that we refer to as blockchain. Hence, the company was called Medical Chain. For those of you not familiar with blockchain, blockchain is something which you would have heard more about, something called Bitcoin, for example, which is a cryptocurrency. But essentially, this is a system which is very powerful in becoming trustless, decentralized, and the idea is that not one person holds it, not one server holds this information. So it's got a very high level of security, and something which, as I say, functions very well in the cryptocurrency world, and it's trying to take this technology and apply it to other areas of our day-to-day life where also high levels of security are needed as well. Doing this as a clinician was very challenging. So in 2017, 2018, 2019, I was GP training at the time. So I was juggling full-time GP training whilst trying to run a business. I was asked by my TPDs at the time, my training program directors, do you think you need a sabbatical? Do you think you need to go part-time? And thankfully, the decision I made was no, I just want to finish training as soon as humanly possible so I can really focus on my business and not lose out on qualifying as a GP as well. As you can imagine, I'm summarizing that into a sentence for you. That was actually lots of conversations, lots of high pressure talks, lots of is this the end of my medical career? You know, if I say this or I do this. And I was really blessed to be a Leeds trainee, and I had fantastic training program directors who, as long as I wasn't getting into trouble, they didn't mind what I was doing. And that was generally the gist of our conversations. As long as you're passing your exams, as long as you're hitting your milestones, as long as your clinical supervisors in that specific rotation are happy with you, we don't have a problem with you. So they were very, very supportive of me to carry on my journey. We managed to be a successful company. We raised $24 million. We opened offices in London, offices in Switzerland as well. And I was still doing this, as I say, as a GP trainee. And I remember awkward conversations with my clinical supervisors. Every time I started a new rotation, I would have to explain to them, hi, I'm Abdullah. I'm your second year GP trainee or final year GP trainee. I'm fully committed to the training program. However, I do have other commitments outside the program. And if you could give me some flexibility with my time when I need to travel, when I need to present, I'd really appreciate that. That was the easy part of the company, was navigating that stuff. The difficult part of the company was trying to learn on the go how to communicate with our developers and our tech team. So one of our brother-in-laws as well was our chief operating officer, and he's somebody we relied on to stay on top of the technology. You call them the chief technology officer, and sometimes things would get lost in translation. So I can give you two particular anecdotes, and I'm hoping these kind of stories are the lessons that I learned that I would have preferred not to have learned the hard way, and hopefully you can overcome these problems as you're going along your journey. So one of them, for example, was when we were building the platform that you would land on, it was, for example, a telemedicine element. So in the introduction Jung made as well, I also made a telemedicine system called myclinic.com, which was used in over 90 countries around the world. And I would explain to the developers that the call needs to be an open call so that we can communicate like Zoom or like other similar platforms out there. The developers then said to me, okay, but if we're going to book patients in for appointments, roughly how long is the doctor's appointment? I'd say, well, the appointment needs to be, say, 15 minutes. If you could make it 15 minutes and book the patients in one by one, and we create a kind of open waiting room that the patients wait in, they can just sign in and wait there, and the doctor can pull them one by one into their clinic. So we were testing this system, and we tested it in a clinic in Southwest London. And I remember the call, great feed, excellent microphone. I could see the patient's records there. It was working really, really well. And then you got to 14 minutes 58, 14 minutes 59, 15 minutes, the call just went dead. And I looked at the developer and I said, we've lost the signal. I said, no, that's just the end of the call. I said, what do you mean it's the end of the call? We're still talking to the patient. You can't just cut the call dead. And he said, well, you just have to start another call and then have to wait again. And you realize that there is this kind of disconnect between what you take as a clinician as common sense, but from the technical perspective, they will tell you and they will deliver exactly what you told them. So a good anecdote of this is if you ask 4 people to draw a picture of a house, they will all draw you a picture of a house, but they will look completely differently and they will follow the instructions you gave them. So one of my learning points here was you have to be very clear with what the specifications are of what you're building, because the technology people in your company will deliver what you want to the specifications that you made. And if you weren't clear, then they are not going to know that stuff. It's not their field. Medicine is not their field. To give you another example, we were talking about the patient records, and the technical guys were asking me, okay, so what bits can the patients manipulate? And I said, well, the whole point is the patient can't manipulate the data. So as a doctor, when the patient shares their medical records with me, I know that only another clinician could have inputted this data. It's not been tampered with. It's not been deleted. It's not been corrupted in any way, apart from their allergies. And then the technical guys looked at me and said, what do you mean about the allergies? And I said, well, the patient has to guide us on what their allergies are. They have to have the ability to input that information into the system. They couldn't get their head around this. They said, but this is so complicated. If we're going to write the code, you're going to say that we have to write a separate code just for allergies. And I said, yes. And they said, but what if the patient says they're allergic to something and they're not? And I said, well, that's our common day practice. The patients will say they're allergic to penicillin all the time, and we don't know if they are or they're not, but we don't take that chance. We just go on the word that they've told us. And then the technical person's solution to me was, well, why don't we just give them penicillin and see what happens? So again, you have this complete disconnect between our side and their side. And the reverse, when I've asked them to make changes, for example, one of my inexperienced moments is asking them to make huge changes, which to me sound very minimal. I might ask them, could you change the button from red to green? Could you just take that button from there and put it in the bottom corner? Could you make the flow of the patient's journey go this way? And I don't realize I'm giving them about 4 to 6 weeks work of coding that they need to go through to make these changes. So these are my experiences that I went on my journey, building medical chain and building my clinic. And for me, the questions I commonly get asked, and I'm not sure if I'll get asked them here, but is, do you think that you should have left medicine to pursue this career, or do you think I should leave medicine to pursue a career in health tech because I've got this fantastic idea? And I think seeing me now on this video call is testament to my decision making here. I love being a doctor. I'll always love being a doctor. It doesn't matter what we raised as a company, how well we did financially as a company. This is my identity and this is who I want to be. And I still have my financial projects and my other kind of business pursuits outside of medicine, but you can have both, you can juggle both. And that's something that I would try to stress to the people listening to this talk, that you don't just have to pick one. It's all about juggling things, and it will come down to your personal circumstances, where you're living, your family support, are there any people depending on you, be that children, be that any elderly, be that anybody with any health problems. So you will know yourself what is the best way to juggle your medical career as well as pursuing something in health tech. But I would always try to implore you that there is a way to do it, and you just need to depend on those around you in order to realize that dream. So that's the first take home point I'd say, is I'm coming to my final minutes of speaking. The second take home point I would say is, in my experience as medics, we are very secretive in nature, in the sense that we're worried we have a really good idea and we're worried who we're going to share this with because they might take our idea. And we're worried about trying because we might expose ourselves to what will happen if we try, and we really don't like the idea of failing. And I say these two ideas are unfortunately very unhelpful when you're trying to pursue a entrepreneurial life or a health tech life, because you own 100% of nothing. So the idea is that you need to share your ideas with other people that are going to make your ideas come true. There's no point in you having 100% of nothing. You need to talk to the other friends, family, people that have other skill sets that are going to support you in this journey. And you also need to try. So they always say that perfection is the enemy of good. And the idea beyond that is you need to just put anything out there. It might not be perfect. It might be a minimal viable product. It might be alpha testing, beta testing, whatever it is. You need to go on that, because the quicker you get feedback from your users, the quicker you're going to change and move and progress to the next version and the next version and the next version to deliver something that somebody will actually want. And the last point actually just comes to mind before I wrap up, is very, very important to clinicians on this call, is that a good idea is not necessarily a good business idea. And that's something I really, really need to stress to you. You may have a fantastic idea. Let's give all the nurses on the ward iPads. They can write down all the observations. It'll go back to some central database. AI is going to then pick which patients on the ward are the sick ones, and will plan a route through the ward where the consultant will go visit the sick ones first and work their way towards the less unwell patients. Brilliant idea. Where's the business case for it? How are you going to save money? How much is it going to cost to deliver this product, etc., etc. So whenever you have a very good idea, try to marry up whether this good idea is also in fact a good business idea. And if you can combine the two, then you're on to a winner. So I'll pause there in case anybody has any questions in the meantime.
Brilliant. Thanks, Abdullah, for all the advice and really inspiring journey. Please feel free to put your questions either in the chat or the Q&A, and we'll monitor them as we go along. I had a question for you. Have you always wanted to be an entrepreneur, or is that something that's developed over time?
So I think when I wrote my bio and I sent it to you, I've been called many times a troublemaker, and I think troublemaker and entrepreneur go hand in hand. I think when I've gone through my journey in med school, I was always looking for opportunities. I wasn't the brightest. So when we used to do our final year exams, I came third quartile, so third out of fourth. But during my time at university, I worked, I had a job. I worked as a waiter. I worked in a mechanic in a garage. I used to sell mobile phones. I tried setting up a website to do theory tests online for people that wanted to learn how to drive. I became an F1. I wasn't happy with the rotor. I tried changing the rotor. I escalated things to the medical director of the hospital and got it actually changed at Royal Preston Hospital. So I've always challenged things really with the notion of trying to do things better. And then the side benefit or the additional benefits, which I hadn't always envisaged. Sometimes these changes are valuable. Sometimes these changes can actually produce money and rewards that you don't always expect. And I think going through that process, I just grew in confidence to keep trying, putting my neck out there. And thankfully, as I say, you know, we've had 2 successful businesses. I still continue to practice as a doctor. I won an award from Imperial College London as one of their emerging alumni for my efforts in this field. So it's something which I've just grown more and more passionate about. And now I look further afield. You know, I do things such as I own a dental practice, which is pretty random. But I looked at the numbers. I see the way NHS dentistry is going versus private dentistry, and I think there's an opportunity there. And I think when you have this kind of balance of not working 5 days a week clinically, it affords you the headspace to look up above the parapet and see what other opportunities there are. I'm sure everybody in this call is incredibly intelligent, incredibly hardworking. They wouldn't be where they are today without having the attributes that they do. And it's just about trying to reach your potential with those attributes that you have. And that's what I'm always trying to strive for.
Brilliant, brilliant. One of the questions coming up on the Q&A, the concern with embarking seems to be an inbuilt fear of I'm a good clinician, but maybe not a good businessman. Any tips to overcome this?
Yeah, of course. I mean, talk to people, have mentors. You know, this stuff doesn't come from nowhere. This comes from trial and error. This comes from talking to people. You know, I was very grateful. I had great mentors. I'd run ideas by them. You know, some of the best advice I ever got was, you always start your journey because you're passionate about what you're doing, but passion doesn't necessarily translate into a successful business again or a successful outcome. And what does is customer feedback. So you'll start off with an idea and put it out there. But if the feedback you start to get is pushing you in a different direction, you need to follow that feedback. That feedback is actually going to lead you towards where you're trying to get to, rather than being stubborn and saying, no, you know, I really want to do this. This is what I think I see it as being, and this is what it needs to be. Maybe that's not what the market wants. Maybe it's just a vanity project and something you want to do, which is absolutely fine. By all means, if you've got the time and resources to do that, then go ahead and do that. But if you're trying to build something, then you really should follow the feedback. And you're only going to get feedback the quicker you get out there and the quicker you talk to people and show people what you're doing.
Another question, did you only work with software engineers or did you engage a product or user interface designer?
No, yeah, so we had UX designers as well. So we had all sorts. We had a lawyer, we had accountants in the company. You know, we had a firm of about 30 people in the end. So in terms of developers, we had front end, back end, full stack, UX. We had testers as well. And again, it's very easy to spend money. It's very easy to burn through your resources. So I would always advise only spend when you need to spend. So somebody might have said at the beginning, we need to have testers. I would have said, I'm the tester. We don't need the testers. My wife is the tester. I'll give the app to my dad, let him test it. Only till the workload becomes insurmountable or the feedback you need becomes quite critical and technical. That's when I would go out and advertise for a job on, for example, on Indeed, or I'd ask one of the developers if they had any friends in that field and ask them to bring somebody in to help us.
Great. Someone asked, did you take any courses in business, MBA or any health tech courses?
No, nothing.
Last question for you, how to raise funding if we only have an idea of a startup but no minimal viable product yet?
So there are lots of ways, there's lots of ways to raise funding. You can do the simple way, which is friends and family. So you'd go to them as your first port of call and you'd ask them, you know, I've got this idea, I'd like you to support me with this. You can also kind of tangent of funding is sweat equity. So the idea is you're asking people, will you come and work for me? I can't pay you anything, but as we go on this journey, I can offer you more and more shares in what we're doing. So you can always start in that idea as well. Once you become big enough, you can reach out to things such as venture capitalists or VCs or angel investors, which are normally wealthy individuals, and you're going to work your way up there. Again, I think in the beginning, if you watch shows such as Dragon's Den, don't inflate your value unnecessarily. It just puts people off, and it just shows you're unrealistic and you don't have insight. And likewise, value the people that are with you, that are on that journey, and make sure that they feel looked after, because they're the ones that you're going to ask to do something at 2 o'clock in the morning on a Sunday, where you can't ask anybody else to do that.
Thanks so much for your time and your candid advice. I think we've all taken a few nuggets from that. That's all.
I apologize. I need to dash because my clinic starts in 1 minute.
No problem. All right.
Take it. Bye. Bye.
So our next speaker for you is Maria, who's a bioinformatics and data science research scientist, focusing her work on the intersection of global health, genomics, and data science to drive solutions for pressing public health challenges. She brings insights from Africa's data revolution and is passionate about mentoring and empowering the next generation of scientists. Maria, the floor is yours.
Thank you once again. Double checking if everyone can hear me. I was muted for a second.
Yes, thanks.
Okay, great. Yes, my name is Maria, and I am a bioinformatics research scientist who is also doing data science in my kind of work. And I'm privileged and humbled to be speaking to the audience today about how to leverage health data and AI-driven insights to improve and strengthen public health systems over the British Early Careers webinar. For the purpose of this call, I thought it would be important to perhaps share my academic background to give it context. I have a Bachelor of Biomedical Lab Technology, and this is when I got introduced to bioinformatics. And it was still introductory. Of course, we didn't know much about it, but thankfully, the next following years, they introduced a master's in bioinformatics, and I'm one of the pioneers in Uganda for that course, where I majored, took my electives in virology and big data analysis. And I'm currently doing my doctoral training, what most people in the UK will call the DPhil. In Uganda, we say, yeah, doctoral training or PhD in data science and predictive analysis. And my focus is in HIV research. To just give you an overview of my, of my project, I am aiming to optimize HIV patient care using integrated analysis of routinely collected data. And the aim here is to predict HIV virological failure in resource-limited settings. Now, one of the motivations for this kind of work and project I'm currently working on is, one, there is a lot of data that is collected through the routine care of the patients in clinics. This cuts across some of the demographics, the genotypic data, and all of that. And when it comes to the African context, a lot of this data is available, but there is not, first of all, much capacity to make use of such data. And of course, we cannot skip the fact that there is limited resources and all of that. And so with trainings in bioinformatics and the exposure I have got when it comes to using AI in public health, I looked at a problem that is pending and ways on how to innovatively use such data for intelligent decision-making. And when we talk about AI in public health, there are so many things that come to mind, especially because in the past years, AI has been seen as a villain, as it's coming over to take over the world, to take over some of people's jobs. We've had this over and over again. But then, of course, I'll pose a reflective question is, when it comes to you and the ways you use AI or the ways you don't use AI, do you think it is strongly a villain or we can use it as an ally? But I understand for the purpose of this call, the people that are on the call are interested in AI. So I think most of us believe and agree that we can use it to serve us and to improve some of the challenges and answer some questions when it comes to research and digital health. And we've seen different ways that AI is used to predict in terms of diagnosis. When we speak of, for example, the types of AI such as the convolutionary networks, the CNN, how they're used to, for example, the MRI scans, how they're able to tell if someone has pneumonia, tuberculosis. And the power in this is that even in resources such as Uganda, where I come from, or Africa in general, some of these tools can be deployed and they're able to quicken the process, to speed up the work, to improve and strengthen some of the public health systems that are already existing. When we talk of things like personalized medicine, for example, my current project where we are working with people living with HIV, and we look at their patterns, we look at the trends that are present in the electronic health records, and how we are able to tell if a person is likely going to progress well or they are going to fail on treatment. And what this does is it helps them to allow interventions that are timely so that a patient is able to be helped, but also it helps with, of course, saving lives and improving overall patient outcomes in general. There are different applications we've seen, like in clinical trials, where AI tools can be used to skim through millions and millions of data points and single out which are the candidates that, or the participants that would be fit for a particular study. This is all possible because we have some of these tools. Otherwise, doing it in a manual way would be cumbersome and almost close to impossible. Of course, when we talk of streamlining administrative operations, when it includes like triaging patients, setting up appointment for the doctors. In Uganda, for example, in 2012, there was the introduction of the Rocket Health, which is telemedicine, a service provider that came and changed the dynamics in the way that patients receive care and treatment. They can have consultations via WhatsApp. And it, isn't the process for both the patients, the clinicians, and it brought healthcare in just a fingertip. And of course, for clinicians or doctors who might be on the call, understand how medical scribing quite of takes time. So to use such tools and robots and all the tools that we can access to save time and take some of the notes of the patients, it's interesting when we see how much time we can save, so that time can be given then back to patient care, to patients and doctor interactions, because that is still needed. And yes, I'll just leave a quote here by one of the speakers of a talk at the vice president of the Microsoft Health that said, the world is full of data, and there has been more data created in the last 2 years than in the last 5,000 years of humanity. When I was watching this talk, I was wondering what happens now, because this was spoke about in 2021, but we're in 2025. So yes, there is potential when it comes to the data that is concurrently produced, released, and then it is up to us to see how to merge AI in how to use it for improved patient outcomes. Now, with some of my exposures, I wanted to share some of the data tools, and maybe for any early researchers that might be on the call who might benefit from this particular talk. Briefly, the health data cycle. This is in no particular order, because at some point there will be data capture and collection. You might not need to collect data at some point when it comes to some of the projects that you're working with. But what the highlight here is for me is that at every step of this health data cycle, the quality of data matters, and how you handle each of these processes when it comes to data capture, collection, it comes to its use and storage. All this matter in the long run. And especially from my experience, when it comes to the fact that I'm an end user of data from such spaces, I find that it is important to keep the integrity of the data without sabotaging some of the processes. And from my exposure at the University of Oxford, I wanted to just highlight some of the tools that the group at the Pandemic SARS Institute has developed. People might get to use these as they are used in some of the outbreaks. One is the ARC, which is highlighted in red, that helps to capture some of the patient data. These are standardized forms, and they cut across different, every person, every patient, every researcher, clinician can customize them to their need. You can explore more over at Isaric. And then other tools such as the Bridge and then the Vertex, which helps with analyzing some of the already collected data. An interesting topic for me when I was called to have this talk, I kept thinking about the data revolution in Africa, and maybe I'll spend some time here. When it comes to Africa, most of the perception that people that are not in Africa have interacted with, and also the common notion is that Africa has a lot of public health challenges, but I want to channel our mindsets and sometimes thinking in the sense of it's not just a site of some of those challenges and public health problems. And it's not only a data provider, because we've seen that many times with going projects, people come to collect the data, but when it comes to seeing that the collectors of the data or the source where this data is going to benefit as much, there is an imbalance there. And so when it comes to AI and public health and data revolution in healthcare, it is important to change our perception. I know that there is a lot of innovations and leadership when it comes to data in Africa and its landscape when it comes to health data and public health outcomes. And we've seen so many health data innovations that the world can learn from. To highlight, for example, the H3 Africa, that was a project running over 10 years that worked with different organizations and institutions in Uganda to develop fund some of the research that is happening. And this led to, of course, generation of a lot of data, genomic data, that now many projects are using to analyze. I've also highlighted some of them here. And yeah, also to look at ways we can have like important yet critical conversations when it comes to addressing some of the Africa's data challenges or opportunities that there are. To see this as a call for partnership and not entirely taking over the contributions from Africa, for example, but to be open to create, to learn and build with some of the African scientists. And I believe that this is the right platform because this topic was called upon to have. And then, of course, to promote inclusive AI. So yes, of course, when you talk of AI in data health and public health, my experience has been that there are some inequalities, of course, that are common. Some have been highlighting previously. But I know that when we look at them as tomorrow's opportunities, especially for people who want to go into AI and data health and public health in general, we can look at ways of course, breaking some of the inequalities that are there, increase the transparency of data. And of course, we cannot neglect some of the challenges such as limited resources and some of the updated information when it comes to pipelines. So it's a call for people to continuously update some of the changes in the pipelines. And looking at the biases, we believe that, of course, AI, we cannot entirely trust it because it is human developed, and as such, it's susceptible to some of the biases that we have as humans. And an important thing is, of course, to look at the data quality as clinicians, as researchers, as healthcare providers in the different spaces we work from, looking at what kind of data is developed, how is it processed, looking at the completeness, issues to do with missingness, and all of that, to make sure that the downstream use of the people that use this data for research are able to make such good interpretations of the data. As we know, the common slogan that what you're giving is what you get out. I'll try to wrap up and, of course, just highlight some of the ethical considerations as we talked about. But one important thing that I wanted to highlight is that as we are training these models, I think it would be interesting for us to train the algorithms to say and admit that they are uncertain, that they are not able to predict something, as opposed to them giving a wrong diagnosis or prescription. Can we be able to train them to admit that they're uncertain and that kind of thing? So because I am still a PhD student, well, I'm almost finishing my study, I just wanted to highlight some of the tips from my experience so far. As early career researchers that might be on this call, anyone who this is relevant to, I just want to encourage you that when it comes to AI and leveraging some of the data in public health, learn to stay curious about the things that you want to learn. For example, there's so many courses on ADX, on TGHN, that's the Global Health Network, on Coursera. I personally, when we didn't have exposure to bioinformatics in Uganda, this is what was helping me to back up some of the skilling that I had. And of course, build your network before you need it in different ways, show up at events. Even when it's not perfect, attend workshops, increase your visibility, just like the previous speaker was talking about. Talk to people as much as you can, because it's from such connections that you get feedback and people and networks that take you forward in terms of your career. And many times I've spoken and shared about my work in different conferences, locally, internationally, and some of the feedback I've got have helped me tune my research in a better way and give me a better understanding And of course, resilience is a skill. When you're starting out in career, this is not a trait you come with that you know I have it. It's a muscle that you keep building. So go out there, show up, and of course, balance breadth with depth. This helps when it is good to know and be curious about many things, but at least focus on a thing or two so that you're known for that. Be committed to something that helps with learning and going forward. And yes, to conclude, I just want to say we are called to not only think of the future, but act in the present. And some of the things I think about is with the vast use of AI, can we include this in some of the public health education, in the curricula? And of course, encouraging people that are interested to build such models and using AI to continue consulting and evolving the policy makers, AI developers in the different areas that people are. And of course, we need to have transparent reporting when it comes to AI and how these models learn and evolve. And yes, we can do amazing things in AI, in public health, if we all do our work in a way that is ethical and relevant. Thank you so much. I don't know if I overshoot with my time, but I'll stop it at that. Yeah.
Thank you very much, Maria. We've already got a question for you. Biases in healthcare and health research have been pervasive throughout history. You mentioned that you'd like to train AI to understand when it's incorrect. Are there any other guardrails or features that you would wish for regarding using AI and large language models in medical practices and research?
Could you please say that again?
Yes. You mentioned that you'd like to train AI to understand when it's incorrect. Are there any other guardrails or features that you would wish for regarding using AI and large language models in medical practices and research?
Yes, maybe one I thought or I could think about for now is definitely training it to notify when it's unsure, so that the users can then know that it's not certain, as opposed to some of the conclusive ways it gives the analysis and diagnosis. And maybe one way this is evident is looking at some of the accuracies and of the models and how they come up. Yeah, that's what I can think of. But there are more ways to explore in how to bring this into clinical practice.
Yeah, brilliant. Thanks, Maria. Right, we're going to move on to Jan now. Thanks. Jan is the current head of health and care at the British Computing Society. She specialises in digital health and social care and has managed complex and innovative work programmes at the forefront of a wide range of NHS settings. Previously, as business manager of the Faculty of Clinical Informatics, she managed the organisation from its early days to a vibrant UK-wide multidisciplinary professional membership community. Thanks for speaking, Jan. The floor is yours.
I'll just share my screen. There, can you see that?
Yeah.
Yep, lovely. Okay, so thanks. It's lovely to see so many people here today, and also to hear the inspiring and interesting talks from Abdullah and Maria, and to see how varied careers are that are available in digital health and care. So I'm just going to talk a bit about the way that BCS can support health informatics careers. So starting off with who is BCS? Who are we? Those of you who are members will obviously know. Those who aren't, hopefully you'll think about joining. So we're the Chartered Institute for IT. So that means that we, an IT almost sort of sounds like a misnomer, because we have membership.
Jan,
yep.
Sorry to interrupt you there. People are commenting they can't see your screen. We're just seeing yourself.
Ah.
That's better.
That's better,
Thank you.
Apologies.
Thank you.
So BCS, the Chartered Institute for IT, we have a membership of around sort of 70,000. We've got about 3,500 at the moment people who are working in health and care, and in a very diverse type of roles. So moving on. So a career is as you know, very long, takes a very long time. And so it's really important to think about how you can sort of plan and also make sure that what you're doing in your digital and clinical career is valuable. So I'm going to sort of cover a few things that you might think about in planning your digital career. One of the things that BCS has is something called the Skills Framework for an Information Age, which is a competency framework that covers all the sorts of different skills that you might have when you're working in a digital or a data or a technical role. It's available on the website, and I've included the link in here. And it's probably worth having a look at to see the skills that you're interested in and how you might go about developing them. So that's something that you might want to have a look at, and it covers all sorts of skills and competencies that are important in digital roles. You might also have a look at some of the role profiles that have been developed by BCS working with the Federation for Informatics Professionals. So we've developed around 206 roles covering all sorts of digital data tech areas, including ones for clinical informatics, clinical safety, CCIO, and clinical informatician roles. And again, it could help you in sort of thinking about the kind of skills that you might need to develop in the roles that you want to move into. So having sort of thought about that, well, how to go about developing the skills that you need. And I think it was Maria mentioned networking, really, really important. And BCS has got a number of specialist groups in health and care, as well as the primary healthcare group. There's some others that are listed here. And so have a look at the specialist groups and see which ones are of interest to you. Really gives you an opportunity to learn, to share experience, webinars, events, that sort of thing, to give you an opportunity to link up with others. And we have ones as well in areas outside of health and care. So if you happen to be particularly interested in cyber or project management or agile or user experience, then there are opportunities to get involved in those too. The Faculty of Health and Care, of which the Primary Healthcare Group is a part, we put on a number of events each year. There's a Primary Healthcare Conference that's coming up, really good conference, 12th to 14th of November, which has an education day as part of that 2-day conference, a nursing conference, and an electronic healthcare record summit. So we have a number of different events, again, opportunities for networking. There's a newsletter that comes out every month, and the link, the LinkedIn link to the newsletter is here on that slide. So do have a look at that and see what there is that might be of interest to you. We have on the website, we have lots of CPD resources. If you go into Discover, you'll find various resources there. Some of them are articles, some of them are webinars like this. There are also some courses as well, which may help you to develop the skills that you need. And we have publishing as well. So there are books if you prefer your learning in that way. And then there are some professional qualifications as well that BCS provide. So these are more sort of in depth. They start at foundation level and beyond, and they cover a number of different areas. So again, have a look at those, and the links are there for the professional qualifications. Some are online, some are face-to-face. And we also have an international healthcare CIO qualification as well. So take a look at those. And then finally, we offer professional registrations. So obviously, if you have a clinical registration, you already have that professional validation of your clinical work. there are registrations available for the digital area, the digital and data area of your work. And some of those are on screen here. So we have the Chartered IT Professional, and we also have the Federation for Informatics Professionals. The Federation for Informatics Professionals, that's a registration that's for people who work in health and care specifically. And you appear on a public register which indicates that you are working ethically and you're working competently within your chosen specialism or your area of informatics. And it's done by application. So it's not based on qualification or education, it's around the experience and skills that you bring. So professional registrations through FEDIP. One of the things that Yumisi mentioned was the Future Digital Leaders. The Federation for Informatics Professionals has a cohort each year. I think it's about 20 people who are supported through a fellowship, through a Future Digital Leaders program. And they'll be going out to look for the cohort for this year. So if you're interested in being involved, have a look at the Faculty of Health and Care newsletter in May, and that will have sort of further details about how to get into the FEDIP Future Digital Leaders program. So that's a quick run through of the ways in which BCS can support you in your career. And my email address is there as well. So if you've got any questions sort of after today, then do get in touch. Thank you.
Thanks very much, Jan. Very informative overview. We had some questions that were pre-submitted. If I can start off with those. Bex, if you can bring Maria back on the panel as well, that'd be great. So first question, how can we start helping clinical staff do digital without having to leave the NHS?
Shall I?
Yes, go ahead, Jan.
I mean, there are lots of opportunities, as you know. You're talking about the sort of, the looking for opportunities, looking for the open door, and particularly where organisations are implementing electronic patient records, or there's an opportunity through a QI programme or a change programme supported by digital. It's being aware of sort of opportunities, I think, but which there are lots in the NHS. And that's sort of, that getting that balance of clinical and informatics.
Excellent. And similar to...
I was just going to, as a clinician who's taken forward that exact approach, so I continue to work in the NHS. I've been in a clinical informatics role probably for at least 10 years now. I think there are definitely possibilities to do that without leaving the NHS and going off and doing entrepreneurial things, but that's not to criticize that route plan. There are lots of, as Abdullah quite clearly said, there are lots of different ways to take this forward. The key thing is trying to connect, as our second speaker was saying, connect with a network, find the digital health lead for your area geographically or for your specialty. Try and build a network to connect with them and trying to use that to help you move forward. I would say that the position I've ended up in, and I'm probably now worryingly regarded as long in the tooth, I've got these grey hairs.
Let's get the answer to that on that.
That it's more been very much by serendipity than direct planning. But I think the key thing is it's all about the connections and the networks that you can do. So there are definitely opportunities for you to continue to work in the NHS and in a health role. Thank you.
Thanks, Ian. Another question for the panel. Maria, if you can come back on as well. How best to deal with rejections on applications to digital roles when feedback seems to be a rarity?
There is one way around that is, first of all, feel bad that you've been rejected, but keep applying. That's one of the things I got to learn. But also the other thing would be to look into your application and see, because sometimes when there is a rejection coming from let's say an applicant, from people that are like admitting, it's because either you didn't follow the criteria, are you eligible for that kind of thing? So look at what their criteria is. If you fit all of them, have someone to read through some of your personal statement and related things. And if you find that you've done all you can and still you're not taken, just look for the next opportunity, because sometimes it's not because you're not good enough, but it's you increasing your chances to be selected. So yes, proofread, ask someone to go through some of your work and apply as much as you can. I think that's where we tap into some of the resilience we talked about. Yeah, it gets better. And of course, the right opportunity eventually lands you. Yeah.
Yeah, great. So yeah, last question, 20-second answer. What advice would you give yourself earlier in your career? Quick fire. We'll start with Jan.
I think I would say really look out for opportunities when they come up, and don't feel, because I'm not in digital, I can't get into digital, because there's lots of different ways in.
Great, thanks, Jan. Maria?
I would say speak a lot about your interests and the work you do, even when you're perhaps in different spaces, because sometimes there is always someone hearing. So increase your visibility by speaking about your work in many spaces.
And Ian, any advice you would give to your earlier self in your career?
I think the key thing for me is probably not to worry about where you are at a particular time, but to continue to keep working on and on at where you want to try and get to. It's all about focusing on that future goal. Thanks.
Brilliant. Well, thanks very much to both our panelists, our speakers, and all for attending. We'll send some more information and yeah, useful things in the post-event email. All right. See you all soon. Take care now. Thanks for attending. Bye-bye.
Thanks, John.
Thanks.